everybody, welcome back to the channel. Or if you're new here, my name is Talisi. I do stream a variety of games over on Twitch, so you can usually catch me live on there. I am also currently a grad student. I am studying forensic psychology, working on my master's, and I am working toward becoming a licensed professional counselor as well. So, still have a little bit to go with that journey, but I do sometimes create content where I talk about different mental health disorders and talk about diagnosis and just kind of cover some, potential causes, treatment, that sort of thing. So just bear in mind that I am not a licensed professional, so none of the information that I share is meant to be taken as any type of treatment, clinical diagnosis, anything like that. Just think of this as kind of an overview, like a basic overview, maybe like an introduction into what diagnosis is for these different mental health disorders. It may spark your interest. It may, kind of give you a little bit of information you didn't know. It may lead you to maybe checking out other professionals who also create content and can provide more in-depth information. But there was some interest within my community for me to start talking about some of these things, and honestly it also just kind of helps me study. So by the time I am a counselor, I want to make sure that I am the best counselor I can be. So creating this content not only helps me study, but it also helps people who have a general interest. And if you would like for me to maybe provide you with some of the professionals that I have found online, I can go ahead and do that, as they can provide content as well. They provide a more in-depth look, and can also provide some of their feedback from their time in the field as an expert, which is something that I cannot provide. Again, I am simply a grad student trying my best. So today we're going to be talking about bipolar disorder 1 and 2. And again, we're just going to kind of go over diagnosis, maybe just a little bit of additional information. So this is meant to be more of like a general overview, not necessarily super in-depth, but it is going to be a lengthier video. Usually I stream these videos live on Twitch as well, and then just simply upload to YouTube. But just because of the length of the video, I thought this one would make more sense for me to just simply record and upload. But in the future, we will be going back to streaming these live. And by the way, if you want to recommend a mental health disorder that you would like for me to talk about and cover, you can either add a comment in the YouTube link, or if you join my Discord, which I will also be providing the link for that as well, you can join my Discord. And there's also a channel in there where you can present, you can type out any recommendations, and I just basically kind of go by order, or if there's an expressed interest in one particular disorder, then I will prioritize that. But with that being said, let's go ahead and get started. So like I said, we'll be covering bipolar disorder 1 and 2. So we're going to go ahead and start off with bipolar disorder 1. So for this, the diagnostic criteria for bipolar 1, there does have to be a manic episode, at least in the lifetime. And I should say the criteria for manic episode includes that for at least 1 week, there is an abnormally persistent, elevated, expansive, or irritable mood. So this is kind of like that on top of the world type of feeling. There's also an increased activity or energy. So people are very energized. Sometimes this usually happens during the hours where the person would normally be asleep. And somebody who's in a manic episode will also experience this for most of the day and nearly every day. One note about this as well is that any duration is considered for diagnosis if the individual required hospitalization. And during the episode, there also need to be 3 of the following symptoms present. So we're looking at inflated self-esteem or grandiosity, decreased sleep, and this includes like if the person feels rested even with only 3 hours, They are more talkative than usual. There's a flight of idea or racing thoughts, and this includes like their subjective experience. They are easily distracted, and there's an increase in goal-directed activity, so social, work, school. It even includes like sexual activity or psychomotor agitation. So this is activity such as anxious restlessness, body movements such as tapping fingers, just unable to sit still. The mood disturbance does cause an impairment in socially or occupational functioning, or there's a necessity of hospitalization to make sure that the person doesn't harm themselves or harm others if there are psychotic features. We did discuss psychosis and psychotic features a little bit more in the schizophrenia video, so go back and check that out if you want a little bit more information about that. And the episode is not caused by any other substance such as like drugs or medications or a separate medical condition. So when you go to therapy, the therapist really should be asking questions regarding your other medical conditions. They really should get a good sense of everything that's going on in your life in that sense, to understand and be able to rule out other medications or other conditions. So they should be able to understand your medical history. So yeah, the next criteria is for a hypomanic episode. So for this, there's an abnormal and persistent elevated irritable mood, as well as the increased activity or energy that lasts at least 4 days consecutively. So this should also be present for most of the day and nearly every day. We're also looking at 3 of the following symptoms, and a lot of these are going to sound very similar. So we're looking at 3 or more of the following symptoms. So there's inflated self-esteem, grandiosity, decreased sleep, which also, like mentioned before, the person is rested even after 3 hours. They're more talkative than usual, flight of ideas, racing thoughts, easily distracted, increase in goal-directed activity. So like we mentioned, work, school, sexual activity, or psychomotor agitation. So there's restlessness. Being overly involved in risky activity. So this is different from a manic episode. So this includes like buying sprees, sexual indiscretions, risky business investments, that sort of thing. And the episode is associated with a clear change in functioning that's very unlike the person when they're not experiencing symptoms. So there's a very clear distinction between what the person would normally be like and when they're experiencing these symptoms. It also includes when mood disturbances can be seen and observed by other people, and the episode is not severe enough to cause an impairment in occupation or social functioning or a need for hospitalization, but if there are psychotic features, it is considered a manic episode. Hypomanic episodes are common with bipolar disorder 1, but they're also not required to meet diagnosis. And then we also want to look at major depressive episodes. So 5 or more of the following symptoms need to occur during the same 2-week period and are also a change from their normal behavior. So at least one of the symptoms is depressed mood or loss of interest and pleasure. So the symptoms that we're discussing here include depressed mood for most of the day, nearly every day. So this could be, from the person's subjective experience, so their own lived experience, or an observation made by other people as well. There's less interest or pleasure in most or all activities during the day. There's a significant weight loss that's not attributed to like dieting. So if the person is purposely trying to lose weight, or there's weight gain. So we're talking about more than 5% of weight in a month, or decreased appetite that happens nearly every day. We're also looking at insomnia or hypersomnia, so not sleeping or excessive sleep. Psychomotor agitation or slowing down that's kind of noticed by others, so this is not only subjective. Others can observe that as well. The next one is fatigue or low energy most of the day, Feelings of worthlessness, excessive inappropriate guilt. So this can also be considered delusional. And keep in mind that's like a very clinical term as well. It's not necessarily meant to be insulting. So there's kind of a difference between the terminology that's used in the clinical sense and how we sort of use it normally in society. So this is not meant to insult anybody. It's just more of a clinical term. The next one we're looking at would be inability to think or concentrate, indecisiveness nearly every day. Again, this is subjective, or it can be something that others have noticed as well. And then there's also recurrent thoughts about death, suicidal ideation without a specific plan, a specific suicide plan, or a suicide attempt. Next criteria is that symptoms cause clinically significant distress or impairment in social, occupational, or other areas of functioning. So yeah, when we talk about clinically significant, I can't even speak. Clinically significant. That's we're kind of talking about like the severity, right? How much does it affect that person? And the episode is not occurring as a result of any other type of substance or medical condition. One thing to note is that major depressive episodes are common with bipolar I, but they're also not required for a diagnosis. Another consideration that's made here are other, significant life events that can cause these symptoms. So, I mean, if there was like some type of tragedy, some type of tragic loss, somebody lost their job, or significant life events that occurred which could explain those feelings. So this is again where the clinician should be gathering enough information to understand your experiences and be able to determine whether or not it's a diagnosis, or it could be considered for diagnosis, or if it can be ruled out as well. Okay, and then some additional considerations for bipolar I is if there's been at least one manic episode, that is not due to another disorder, which does include some other conditions such as like schizoaffective among some of the other schizophrenia spectrum or psychotic disorders. So again, we do have a video on schizophrenia. You can go back and watch that if you're interested at all. And some additional considerations are made to basically specify the diagnosis and kind of outline some of the features. I didn't go into detail on these because these are just more specific for clinicians and other professionals, who use the codes to diagnose. But there are some additional specifiers. I also don't want to make the video too long, so there are also some additional specifiers and considerations that a professional makes when diagnosing. Okay, and then so now for bipolar II, a lot of this is going to sound the same, so I might run through it a little bit more quickly because we did just sort of discuss it for bipolar I. And yeah, there's a lot of similarities there. So for bipolar disorder 2, the first part of the diagnosis is a hypomanic episode. So hypomanic, again, would be an abnormal or persistent elevated irritable mood, as well as increased activity or energy that lasts for at least 4 days consecutively. And this should also be present most of the day or nearly every day. It also includes 3 of the following symptoms. So inflated self-esteem, grandiosity, decreased sleep, feeling rested after only 3 hours, being more talkative than usual, flight of ideas, racing thoughts, somebody's easily distracted, increase in goal-directed activity, which includes like at work, school, sexual activity, psychomotor agitation, so just being really restless, and being overly involved in risky activity, which includes like buying sprees, sexual indiscretions, risky business investments, anything like that. And then the next criteria is that the episode is associated with a clear change in functioning very different from what the person would normally be like when they're not experiencing symptoms. Mood disturbances can easily be seen by other people, so it's not only limited to a subjective experience. And the episode is not severe enough to cause impairment in social or occupational functioning or the need for hospitalization. But one thing to note is that if there are psychotic features, it is considered a manic episode. And it also cannot be attributed to another substance. So we're talking here, like I said before, we're talking about like drugs, medication, or any other type of treatment or medical condition that would explain the symptoms better. And then the next criteria would be a major depressive episode. So 5 or more of the following symptoms occur during the same 2-week period and are also a change from regular behavior. At least one of them is depressed mood or loss of interest or pleasure. So the first of those 5 symptoms is depressed mood for most of the day, nearly every day. This could result from a subjective experience, so the person is explaining the symptoms, or an observation that's made by other people. Less interest or pleasure in most of the activities during the day. Significant weight loss when they're not purposely trying to lose weight, so they're not dieting or anything like that. Or a weight gain if it's more than 5% of weight in a month, or a decreased appetite that occurs nearly every day. The next one would be insomnia or hypersomnia. So somebody is either not sleeping or there is excessive sleep during the day. Next one is psychomotor agitation. So again, restlessness or slowing down that's noticed by others. So this is also not only subjective. Fatigue or low energy almost every day. Feelings of worthlessness or excessive inappropriate guilt that happens nearly every day. Inability to think or concentrate, indecisiveness nearly every day, either subjective or observed by other people. Recurrent thoughts about death, suicidal ideation without a specific plan, a specific suicide plan, or a suicide attempt. So again, any 5 of those symptoms. The next one would be that symptoms cause clinically significant distress or impairment in social, occupational, or any other areas of functioning. And the episode is not occurring as a result of another substance or medical condition. And again, we're also considering, major life events like I mentioned before. So there's like a tragic accident, somebody just lost their job, lost their house, anything significant like that. And then some additional diagnosis considerations. If criteria was met for at least one hypomanic episode, or criteria requires at least one hypomanic episode and at least one major depressive episode. Also, if there has never been a manic episode, because that's one of the differences between bipolar I and bipolar II. And if there's at least one hypomanic episode and at least one major depressive episode that's not better explained by schizoaffective or some of the other schizophrenia spectrum or psychotic disorders. So again, same thing as we said for bipolar I want to state that there are some additional considerations that a clinician would make based on all of the symptoms and experiences of the person, which I didn't include any of the codes. So again, that's just more for professionals when they are diagnosing. So it just sort of helps to narrow down exactly what the person is experiencing there. So just bear that in mind. I didn't include every single tiny detail, but that's overall the criteria for diagnosing bipolar I and bipolar II disorder. So now I want to go ahead and cover some additional information, some some causes and like developments of bipolar disorder. So for manic episodes, people who experience this typically don't want treatment, or you can say are a little bit more resistant to treatment, because again, they're experiencing that larger than life feeling. um, Sometimes, having they have like a greater sense of smell, hearing, vision. There's higher productivity. So because of their experiencing, it's kind of understandable how somebody going through this would think that receiving treatment or staying or adhering to their treatment would be, in a sense, like slowing them down, right? Um, so that's one thing to keep in mind when people are experiencing a manic episode. And then the prevalence of bipolar I disorder is about 1.5% of the population. So there's no real significant difference between men and women, and it's usually diagnosed in people between 20 to 30 years old. For bipolar II, the disorder can start in the late teens through adulthood, but the average onset usually happens around the mid-20s. And it's also not usually recognized as bipolar II until there's a hypomanic episode. So somebody could be experiencing major depressive episodes and they could be diagnosed with that, but until there's more symptomology for a hypomanic episode, it could, not really be recognized as what it is. And people with bipolar I are also more likely to experience hypomanic symptoms than people with bipolar II. Another distinction as well is that depressive episodes last longer in bipolar II, and they're a lot more disabling usually. Something else to note as well is that if a manic episode occurs, the diagnosis will change from bipolar II to bipolar I. So again, bipolar I is the one that includes manic episode, at least one manic episode, as part of the diagnosis. And then I did want to talk about some additional things, but I sort of split it up between bipolar I and bipolar II just because I didn't want it to get too muddy if I'm like bipolar I this, but then bipolar II this. So I wanted to group them up so that they make a little bit more sense. So for bipolar I, childhood adversity, so this would be something like early emotional trauma, is one of the known risk factors, and the treatment outcomes are usually not as great for people who have experienced this. And I also want to add that this is actually also very true for a lot of disorders. I mean, just childhood adversity in general is a great risk factor for a lot of mental health outcomes. So those are some things to consider. When we think about childhood development and how they really should have a safe, stable upbringing. And so there are also some additional like genetics that are tied to this disorder, and there's some differences based on cultural values. So although I didn't go into full detail on this, it's also very important for clinicians to be open and familiarize themselves with various cultural practices, and if they don't know, to conduct that research and learn more about it, because norms vary so much. So any clinician really should not be applying the same lens or their own lens to when they work with their clients. They really should be open to understanding other people's practices or norms, because there are some very differences there. And then something else that I wanted to bring up again, because we did discuss it during the schizophrenia video, Black people are more likely to be misdiagnosed with schizophrenia when they really could have bipolar disorder. And some of it is because there's a misunderstanding of mood symptoms, or if like the clinician is just not understanding their clients. And there's many times they also show up experiencing more severe symptoms that happens due to lack of treatment, or just really shorter assessments by a clinician if you have somebody who's not taking that proper care. But sometimes people just simply don't have access to treatment. There's more stigma in certain communities than others. So that's why you may see some additional, or more severe symptoms when they actually do show up for treatment. So again, this is also why I highly recommend to just kind of hang on to that nugget of information, right? Because you should be able to either like advocate for your friends, for your loved ones, share the information with somebody else, you know, if you think they've been misdiagnosed, advocate for yourself. So anything like that really helps, because I really do think that we need to change that trend of misdiagnosis, because then people don't receive proper treatment. It's just a part of, you know, how we change and evolve. So that's another reason why I like creating this content. If that information gets to anybody, then I consider that a win. And so a member of our community also asked to describe some of the differences between men and women in general when it comes to bipolar disorder. So I did want to cover a few different things. So women are more likely to experience certain symptoms such as eating disorders, or not symptoms, but like other I don't want to call it a symptom, right? But like other disorders such as like eating disorders. And they're more likely to experience depressive symptoms than men. There's also a higher risk of alcohol use disorder when compared with men or women who aren't diagnosed, or I should say the general population. They also have worse mood symptoms during their premenstrual cycle, and they're affected during perimenopause when their estrogen levels are decreasing. One important thing to note too is that there's no increased risk of mood episodes in pregnant women unless they stop taking their medications during pregnancy. There's also a much greater risk of suicide in people with bipolar disorder. In around 5 to 6% people die by suicide. So the attempts tend to be higher in women, but when we talk about lethal suicide, that is far more common in men. So the risk is even greater when people also have a history of suicide attempt or attempts. So now we get into some of the information for bipolar II. Like I said, all of that was for bipolar I. So for bipolar II, anxiety, substance use, or eating disorders can complicate diagnosis, and depressive episodes can be seen before hypomanic episodes, which we did sort of cover earlier. So usually there's no diagnosis until the hypomanic episode is present. The risk is also higher with relatives of people who have bipolar II, which is different than bipolar I or major depressive disorder. So around 1/3 of people reported that there's a family history with bipolar disorder. And then for our differences between men and women, some samples have suggested that bipolar II is more common in women. Women are also more likely to experience hypomania and mixed depressive features, as well as rapid cycling. So rapid cycling is pretty much, I believe it's when you have like 4 or more manic, hypomanic, or depressive episodes that occur during the same year. So it's like a higher frequency, and that's what rapid cycling is. So next one, childbirth can also trigger a hypomanic episode, and that happens between 10 to 20% of women. This can also be challenging to diagnose because after a woman has a child, you know, they experience like loss of sleep. So it can kind of complicate the diagnosis of that a little bit, just because of all the changes after a woman has had a child. And about 1/3 of populations report suicide attempts throughout their lives, and there are no significant differences between bipolar I and II. And people with bipolar II also have more cognitive impairment, so they don't perform quite as well. There's also longer rates of unemployment, higher rates of panic disorder, as well as lifetime alcohol use disorder. So, when we talk about treatment or think about treatment, I'm going to go ahead and cover like medications first. And so all the information, which by the way, I also have references to where I pulled my information. Again, everything that I included here comes directly and straight from my textbooks. I don't really add anything myself because, again, I don't have experience working with people or anything like that, but I do pull information from my textbooks. I provide all that as well so that you can see exactly where I'm pulling my information. A lot of my psychopharmacological information comes from this lovely book. It is amazing. I still use it even after taking this course because it covers a lot of medications, what they do, why they're used, history behind them, all that good stuff. It's called Psychopharmacology by Edinger. And so for bipolar disorder, one of the most common pharmacological treatments is lithium. So lithium was discovered by, well, I should say, no, it wasn't discovered, not lithium was discovered, but I should say John Cade discovered anti-manic properties back in 1948. Back then, lithium was being used to excuse me, I cannot talk. So back then, lithium was used to substitute salt in patients who had high blood pressure and heart disease, but it was later discontinued because it was toxic and lethal. So we'll kind of cover a little bit more information on that. We'll kind of mention the toxicity with lithium. But anyway, so Cade believed, and by the way, this is going to be kind of like the TLDR version. I'm not going to include the full story, but Cade believed that mania resulted from an excessive amount of normal byproduct of metabolism. Long story short, he wanted to test this, so he injected urine from manic patients into guinea pigs to check his theory. Eventually, he made some discoveries, yada yada yada, and he injected them with lithium carbonate, and the results of that allowed him to test lithium in manic patients. So obviously, there's more details in that story. I'm just sort of giving like a very, very, very simplified version of it. And the use of lithium carbonate gained support, but it actually wasn't even approved by the FDA until 1970. So lithium is absorbed into the bloodstream and it crosses the blood-brain barrier slowly. It is not metabolized by the liver, so it's actually excreted by the kidneys. And it can be lethal because there's like a very small, I guess what would you call it, like frame? Like there's a very specific dosage that can be given, because it can be lethal if you go above the levels that somebody's supposed to receive. And high dosage usually leads to nausea, vomiting, abdominal pain, tremors, slurred speech, among some other ones. And toxicity also happens if there's a sudden loss of salt in the body. Long-term use can result in significant weight gain, thyroid disease, skin rash, kidney dysfunction, and a compromised immune function. So when somebody stops using lithium, that can also be very dangerous. There's a higher risk of suicide or suicide attempts. And the way lithium works, again, this is also a simplified version of it, if you will. The way lithium works is that it kind of changes the release of chemicals that happen in the brain. So it's been shown to increase BDNF, which is the brain-derived neurotropic factor, the BDNF activity in the brain. So BDNF is important for like normal cell survival, receptor growth, and growth of new neurons. It maintains like cell functioning, like normal cell functioning. And it also helps to stabilize, lithium also helps to stabilize the activity of the central dopamine neurons, and it can reverse the damage in some areas of the brain, which include the hippocampus and the frontal cortex. And lithium is kind of considered also like the gold standard for bipolar disorder treatment, but there's also high toxicity. So like I mentioned, there's like a very specific dosage that is acceptable. Otherwise, it can have some lethal consequences. So I recall reading that you also should do like regular blood tests if you're on lithium, just to make sure that you are receiving the correct dosage And if not that way, that can be adjusted accordingly, because it can be lethal. There's also some other drugs that are being used to treat bipolar disorder. So some of these include anticonvulsants. So valproic acid is one of those, and this one is usually tolerated better in people than lithium. And it also helps patients who experience that rapid cycling that we talked about. So where they experience 4 of those episodes within a 12-month time frame. Um, there's also some other additional medications that can be considered as well. So, but these are some of the main ones. And again, all of this should also be, you should be consulting your doctor if you have concerns about the type of medication that you're receiving, right? And I also wanted to talk about some of the therapies that are used, because the type of therapist that I'm going to be at the master's level, I'm not going to be I'm not going to be a medical professional, so I'm not going to be not diagnosing, sorry. I'm not going to be prescribing medication or anything like that. But as a counselor, I should have knowledge of what the medication does, its side effects, all of those things, right? So that I can also properly diagnose and also be able to advocate for clients if we believe that there's something off with the medication. Just work directly with the client to be able to figure that out, because yeah, that's what counselors should be doing. But when it comes to actual therapies, therapeutic intervention, there are several ones that can be considered for bipolar disorder. So even the use of different interventions, that should also happen in collaboration with your counselor. And it really should be tailored to meet your individual needs. So no counselor should just say this is the best therapy, you have no choice, this is what we're using. So there are options out there, right? And there are different ones that have been found to be pretty successful when talking about treating bipolar disorder. So the first is psychoeducation. I would also argue that psychoeducation is important regardless of what the disorder is. But psychoeducation empowers clients by helping them understand the disorder and also helping them figure out ways to manage it by, sticking to your medications if you're on a regimen, continuing treatment, understanding why you should continue treatment, and also understanding your own triggers. I would also say, I already said it, sorry. Yeah, that psychoeducation is important regardless, to be able to understand yourself, understand the type of treatment you're receiving, why you're receiving that treatment, and know whether or not it's effective, right? That's what psychoeducation really helps people with. The next one is cognitive behavioral therapy, or commonly known as CBT. So CBT helps clients understand their thoughts, beliefs, and behaviors that contribute to their symptoms, or what we would consider maladaptive thoughts, behaviors, and beliefs. So CBT may or may not help everybody. So even even when I'm on social media and I kind of look at other professionals who are talking about different types of therapy and stuff, sometimes I look at the comments because I'm curious to hear about people and their subjective experiences. I have seen a lot of people that say that CBT didn't work for them or it didn't help them. It has been researched pretty extensively. And so I want to point out that just because it has been researched, it is effective, doesn't mean that it's going to help everybody, right? So again, this is just one consideration. It doesn't necessarily mean that if you have bipolar disorder, you have to do CBT. So again, this is really something that you should collaborate with your clinician on so that you are receiving, a therapy that works for you specifically. So another example would be family focused therapy. So people that have, you know, less support tend to experience a lot more stress. So this intervention can decrease stress levels by helping to improve some of those relationships. And I do want to note that this would require that somebody else joins and is willing to participate as part of the therapy. So, this may or may not work depending on somebody's situation. So if they don't have a person that can join in therapy and can be part of that experience, this maybe should not be a consideration. There was also another one that I was not familiar with, but it was interesting to learn about it, known as interpersonal and social rhythm therapy. So what to know about this, right, is that unstable or disrupted daily routines will lead to a circadian rhythm instability, which can also have a direct impact on episodes. So social rhythm is known as, like your daily activities, when you get out of bed, when you start doing certain activities throughout the day, when you go to bed. So pretty much your daily activities, what you do throughout the day. So this type of therapy can help by improving your mood and make your circadian rhythm a lot more stable. It also targets some of those stressful life events, medication on adherence. So if you struggle to stay on your medication, you have concerns about that, it's supposed to target some of those things. And it also targets a social rhythm disruption. So it kind of helps with stability, dealing with stressful life events. And the clinician helps the person resolve several problems by understanding their disruptions. And this is also modified for bipolar II disorder. So from what I read, that's usually when it's used. Again, I included a link to the article that I looked at for some of these interventions if you are curious to read that. And the last thing is peer support. So this isn't like a formal intervention per se, but if somebody has peer support, it does help them with maintenance, to, sticking to therapy, sticking to medication, and it helps with self-efficacy. They can also help them avoid isolation and helps reduce stigma. So just having, like a sense of community that definitely helps people, and it's not really just limited to bipolar disorder. So that is the information that I have. Hopefully that was informative, helpful. And like I said, if there's anything that you would like for me to cover, please feel free to put that in the comments. I will be looking at that. Normally, like I said, I do these live on Twitch. This one, just because of the length of the video, I decided to just go ahead and record it. Again, there is so much information out there. I am in no way suggesting that I included anything and everything that you need to know about bipolar disorder. There are plenty of also other professionals that will give you a much more in-depth look and explain things probably much better than I can. But again, this information is pulled directly from like text that I'm using for school. Again, this helps me study, and hopefully there is some value of me putting this information out there as a grad student in case you're interested in going into this field. I know a little something at this point. I can provide a little bit of background and talk about my experience as a grad student. That much I can provide. So if let me know again in the comments, or you feel free to join the Discord. Again, there's a lot of gaming on there, being silly on top of like this very serious mental health stuff. I also have some resources on my Discord as well. They're really good to know. And if you want to know which professionals I look at as far as like their content, I'd be more than happy to send you their way. There are quite a few that I would love to share with you if you're interested. But thanks for tuning in. I hope this was helpful to some of you, even if it's just one person. I hope it was helpful, because I think this is gonna help me when I have to like go back and like study a little bit, you know what I mean? But I appreciate you for tuning in, and until next time, again, my name is Talisi. Have a great one. Bye.